This is Professor Ghulam Siddiq. Today, we are going to present a case of a 25 years old boy who was referred by a hematologist for a laparoscopic splenectomy. Actually, he was a known case of I.T.P with failed medical treatment. Till recently, he was on steroids, and his latest platelet count prior to surgery was only 5,000. I keep the patient in right lateral decubitus and reverse Trendelenburg position. For the ports, uh, 10 millimeter port is inserted uh, towards the left of the midline above the umbilicus, and two working ports, one in the epigastrium, which is 5 millimeter port, and another port is 10 millimeter, which is inserted in the mid axillary line, mid clavicular line, slightly below the camera port. Another 5 millimeter port is inserted in the mid axillary line, which is for the assistant. We start the procedure by taking down the attachments at the lower pole of the spleen. The splenic flexure of the colon is mobilized by dividing the splenocholic ligament. Further attachments along the visceral surface are taken down. A branch of the splenic artery supplying the lower pole is encountered, which is dissected out but is not divided at this stage. Next, the gastrosplenic ligament is incised and access is made into the lesser sac. The short gastric vessels here are then divided to have good exposure of the hilum of the spleen. The splenic artery could be appreciated very clearly by its pulsations, and in hematological disorders, early control of the artery is mandatory. This will prevent further destruction of the platelets, and in fact, once the control of the artery is taken, the platelets can be transfused. For the purpose of demonstration, every attempt is made to display the veins and arteries very clearly. Otherwise, they can be taken together using a ligature. Now, this is a more important part of the operation, and this is our dissection towards the hilum of the spleen. Here, the splenic artery, splenic vein, and tail of the pancreas all join in the hilum. The tail of the spleen sometimes is in close proximity with the spleen, and sometimes it's a couple of centimeters away from the spleen. So every attempt should be made not to injure the pancreas. The spleen is seen here, and which is the vessel that is encountered before the splenic artery, which is a little bit higher in position. There is always a temptation to divide the splenic vein, but that should be resisted, and the splenic artery should be taken first. Most of the problems during laparoscopic surgery and even in open surgery arise as a result of trauma to the vein, which has relatively thin walls as compared to the artery. The artery is clipped and divided, and then the splenic vein, which was carefully dissected, is now clipped and divided. Now here it is visible that the upper pole of the spleen is still looking quite pink, and that is as a result of this branch of the splenic artery, which is supplying this pole separately. This artery and vein both were dissected out, clipped and divided. In the end, the avascular attachments between the diaphragm and the spleen, and also between the spleen and the kidney, are divided. The specimen is then retrieved in an endo bag by making a 5 centimeter incision in the abdominal wall. Hemostasis is secured, the area is washed with normal saline, and a suction drain is placed in the left subphrenic region. His post-op recovery was straightforward, and on the second day of surgery, he was discharged home. Thanks for watching.